This morning we're going to do a presentation on biomechanics, and I was asked to do this by some of the people who follow Present Podiatry online, and I'm very happy to be able to do this. I want to kind of make a disclaimer first. I'm in no way a biomechanics expert. I mainly use biomechanics to help me decide how to treat patients with surgical procedures and also with conservative measures. I do use one system that I do like because it's really quick. At the outset, I wanted to just say that I don't think there's a perfect biomechanics theory that I've been able to read so far. There are probably holes in each one I've looked at. And also, I don't think that really matters. I think if you choose a good system and kind of use that system, to work for you. So this is just the way I use a system we're going to talk about here. And I thought what I would do is do this in a presentation like a lecture. And this is a lecture I've done before in other places. So we'll kind of use the same outline of the lecture that I've done before. So what we're going to talk about treating metatarsalgia. Now each time you talk about a different deformity, you may have different things come up with biomechanics. But we're going to kind of keep this simple, and we're going to talk about how I use particular foot typing in my treatment of people that come in the office of metatarsalgia. Now the first thing you do when somebody comes in with metatarsalgia, you have to know how to work this up, and there are all kinds of ways. There's x-rays and a host of things that we look at to help us decide what to do with the patient. But what I wanted to do was have a way to work up a patient right on the spot before you even do an x-ray, and kind of get an idea of where you're going to go with the treatment for the patient. So I came up with something that I call elf press, and this is a little goofy picture here, but basically what I do is when a patient comes in and they complain of pain in the ball of their foot, I check to see if they have equinus, and I also check for the location of the pain, and then I use foot typing, and also finally something that I published before called the Peacock press. And these are my go-to workups for a patient with metatarsalgia. Now this is not the only workup. Obviously I also use x-rays like most everybody else would, but this is what I look at. Elf press is kind of easy to remember. That's what I do on every patient that will come in with forefoot pain. And we'll go into each one of these a little bit in detail here. Now obviously we want to check for equinus. We all know there's all kinds of different equinuses, but we're going to limit this to gastroc equinus because those are the patients you're going to mostly see that have metatarsalgia. Obviously, you're going to have some people that have gastroc soleus equinus, and those patients are treated slightly different than what we're going to talk about today. Obviously, when you want to use a cervicaloid test, and this is a patient that with their knee extended, they are not getting 10 degrees, but with their knee flexed, they're going to get 10 degrees, such as this patient you see here. So these patients will be a good candidate for a gastrocnemius recession. So we look at equinus, do they have that? And one of the reasons why that's important is that when you do a gastroc recession, a lot of things happen other than reducing the forefoot pressure, which Stephen Barrett has written on, but also it has effect many times in certain foot types on the first ray. If you are not having to pronate to get your foot to dorsiflex, what happens is the peroneal longus has a greater mechanical advantage, and will plantar flex the first ray. So you have to keep in mind that the first ray can plantar flex in certain flexible foot types after a gastroc recession. And this helps us with such things as second met pain, obviously. Now, location is also extremely important. There's a fairly famous paper done by Levantine that showed if you had an IPK in certain locations, it would let you know which metatarsals you need to do osteotomies on. He basically treated metatarsalgia with osteotomies only. I kind of do a combination of things, but I do want to give credence to this because I use this a lot. In other words, if you look at this, if a patient has a third met pain or IPK, you're going to look in the back of your mind as to whether or not you need to do second, third, and fourth metatarsal osteotomies. However, this is not always the case. It depends on the foot type. But as a starting point, this is a real good place to start. Now, I also use foot typing. This is where some of the controversy in Present Podiatry has come into view. It doesn't matter which system you use. I like the foot typing that Dennis Shavelson describes because it's fairly easy to do clinically, and it gives you a really quick assessment. Now what you do, you look at the forefoot and the rear foot and how they relate to one another, and you describe whether the forefoot is either flexible, rigid, or stable, and you describe whether the rear foot is either flexible, rigid, or stable. So it's a fairly simple way to foot type a patient. And let's just go over how you do that. First of all, you establish root neutral position, which we all know is neutral position of subtalar joint and loading of the fourth and fifth metatarsal. If you look at your picture in the bottom left there, you can see that. So the first thing we do is assess the rear foot. And we look at the rear foot in root neutral position. We move the rear foot in a way to where we're going to try to evert the rear foot. And what happens is a stable rear foot will go to midline. So you see how that looks in the top there? A rigid rear foot will remain slightly outside of the vertical line, and you'll have a little bit of inversion of the heel. A flexible rear foot will go past the vertical position. So that's how you will basically type the rear foot, and this will become important later, as you'll see in the talk. The forefoot is slightly more complicated but fairly simple. What we're going to do is go into root neutral position, and we're going to assess the first ray as it moves in relation to the fifth metatarsal. So in root neutral position, if you look at a rigid rear forefoot, when we are in neutral position with the forefoot loaded, if we push up on the first ray and it stays equal with the fifth in supinatory movement, that would be considered a rigid forefoot. If, in addition to this, if you press down on the first ray, it doesn't go past the fifth met. So you see that little diagram shows that. And there are some patients that have rigid rear forefoots. Most of these patients, we don't see that often, though, not in podiatry, unless they have cavus deformity. And we're not going to talk about cavus today, that's a different deformity. A stable forefoot in the same movement, if you push up on the first ray, it'll remain, the plantar aspect of the first ray will remain in line with the fifth metatarsal, but you'll get some plantar flexion, but still in line when you push down on the first ray. And we've termed these supinatory in-range motion for when we're pushing up on the first ray, and pronatory in-range motion when you push down. Now, it doesn't matter what you call this. Some people prefer to call this hypermobile or stable first ray, and they'll basically describe it that way. It's still kind of the same thing. The nomenclature doesn't really matter. That's just words. What's good about this system is you're able to kind of assess a patient really quickly. If you look at flexible first ray or flexible forefoot, if you push up on the first ray in root neutral position, it'll go above the fifth, and when you push down the first ray or plantar flexor first ray, the pronatory in-range motion will be below the fifth. Now, if you take a lot of people and start quantifying people this way, you can see certain things that come up. Now, there's variations in this, but these are the kind of basic foot typings. So what you'll see in clinic, and what we're going to take care of today, is look at this now. So we're going to look at the rear foot as it kind of relates to the forefoot. So you'll have rigid means a rigid rear foot, rigid forefoot, and on down the line that you're seeing here. Now we need to take some of this stuff away because we don't see a lot of this stuff in metatarsalgia. Most metatarsalgia patients you're going to see are going to have rigid rear foots and a flexible forefoot. And that kind of makes sense. If you have a fairly rigid rear foot and you step down and your forefoot's flexible, say your first ray is hypermobile, you could use that term too if you wanted to, obviously you would have pain transferred into the second met. It's a very common deformity we see. So the patients we're going to basically be dealing with, we're going to get rid of our flat foot because those are patients that require much more aggressive surgeries to really correct. Get rid of the rigid because that's our cavus deformity patient. We're not going to talk about those patients. We're going to get rid of our stable because people that have a stable rear foot and a stable forefoot, generally speaking, will not have metatarsalgia unless they've done something to cause it, like overworked or run a marathon or something like that. So here are the two we're going to deal with. When most of the patients that we see, when we use this system of defining the patient's forefoot and rear foot, we're going to see rigid rear foot, flexible forefoot, and we're also going to see patients that are flexible both in the rear foot and the forefoot, and we treat these patients slightly different. So, how does this all go together? Lastly, I use something called a Peacock press, which I've got a publication on, and basically what I do with that, that's just where we kind of guesstimate sort of what the foot would look like at toe off, and we push up on the toes in the root neutral position, and we take an ultrasound and kind of look at the levels of our metatarsals. And this is very important too. A very good procedure to do intraoperatively. We're not going to do that. We're not going to go into that a lot today because that's a different talk altogether. And the techniques that I use are basically I use percutaneous metatarsal osteotomies, gastroc recessions. I use tarsal stabilization. Normally I use the hypocure, and I'll sometimes do that with gastroc or without. Sometimes you have to address the first ray. And there's also, you have plantar plate tears and medial drift. That's another talk as well. So we'll kind of talk about the first four here. We're going to kind of skip this part. This just shows how I do percutaneous osteotomies and the difference between a gastroc recession, open and closed. Everybody knows that. So here's what we have to do. If we have a patient that has a flexible rear foot and a flexible forefoot, we're going to need to transfer that patient into a rigid rear foot and a flexible forefoot before we start doing surgical correction on the patients. Now that can be done in different ways. Hypocure is certainly a great way to stabilize the rear foot. Sometimes orthotics can do this. There's some new research that rehabbing certain muscles can do this. And remember we talked about the gastroc recession. Some patients, if you take care of the gastroc equinus, you'll get plantar flexion of the first ray, and your first ray will act in a more stable first ray. Now, if you have a rigid rear foot and an extremely flexible forefoot, or what we call hypermobile, what we do in his system call this a high supinatory end range motion, be almost the same thing as a hypermobile first ray. With these particular patients, you're going to need to stabilize the hypermobile first ray, or supinatory end range motion of the first ray. You can do that by directly addressing the first ray, in other words, plantar flexing it. Sometimes I'll do cotton osteotomies. These are some patients you may have to do lapis on. Orthotics in some patients can work. And then finally, gastroc recession, as we talked about before. Okay, so here's the formula that I use when I'm treating a patient with metatarsalgia. Basically, if you look at the top, you can see it says location. G stands for gastroc equinus. The PMO is what metatarsal osteotomy you're going to perform. EGR is gastroc resection. You can do that with a scope or not. And first ray, you have to look at that. And also whether or not we're going to do a hypocure or something to stabilize the rear foot. If you look right underneath there in the red, you see we also take into account forefoot type and rear foot typing. So we take into account both foot typing and also what we're going to do to particular foot. You see the RRFF, that's a rigid rear foot, flexible forefoot. Then we have a high supinatory end range motion or a hypermobile first ray. And finally flexible with flexible rear foot, flexible forefoot. So these are all things we're looking at in the formula. Now we're going to look at a specific patient using the formula. Patient comes in and the patient states they have pain in the third metatarsal or points to the third metatarsal. We've got our location. We're going to check for equinus. You see in this particular patient it's negative. We're looking at line 4. So the potential osteotomies we're going to do are second, third, and fourth. We know we're going to be doing that. The thing is, it makes a big difference in which foot type you're dealing with. If you go to the top and look at our red there, if we're dealing with a rigid rear foot and a flexible forefoot, and drop that down, you see that's blank. That means we don't have to do anything else except for the second, third, and fourth metatarsal osteotomies. However, if our patient has a rigid rear foot but a hypermobile first ray or an increased supinatory end range motion, drop that down, you see now we have a red plus there. So we're going to need to do metatarsal osteotomy second, third, and fourth, and do something to stabilize our first ray. Now, if the patient's foot type was a flexible foot, you look at the top right, you see that under that, you drop down. You would have to do something to stabilize the rear foot, preferably what I normally use is a hypercure. That now converts us into a rigid rear foot and flexible forefoot. We have to make sure that there's still not issues with the first ray. So potentially what we would do is a hypercure and osteotomy second, third, and fourth. In addition, we may also have to address the first ray if it continues to be hypermobile after the hypercure. Oftentimes, after you place the hypercure in, it stabilizes the forefoot and with respect to the first ray because there's biomechanical advantage now to the peroneus longus. However, you can also assess this even intraoperatively. And that's one of the ways I use the Peacock press with the ultrasound. Now, let's go to a different page so we can kind of get this down right here. Okay, now we're going to look at another patient, and we're going to drop down to line 2 there. My numbers are slightly out of order here. It should go 1 through 11. I didn't realize that until we started to talk. But anyway, we're going to look at the line 2 that we got colored in red. Patient will come in with a pain with a second met. This is actually something we all see a lot, with our predislocation pain, our plantar plate tears. And we test this patient for Aquinas. We can see that it is positive in this patient. So we know we're going to be doing, most likely, metatarsal second and third, based on the Levantine formula. Now, if the patient has a rigid rear foot and a flexible forefoot, if you look at the top right there, drop down, you see we have a plus mark this time. So in this patient, we're going to need to do second and third metatarsal osteotomies, as well as a gastroc recession. Now, the reason this is important, because if you just do second and third, and you have a patient with gastric equinus, you will most likely get transferred to the fourth met. So we want to do as little surgery as we can and make the patient's foot functional. So you have to address the gastric equinus. Now, if we tested the patient and found out that they had a high supinator end range motion in the first ray, or what most call the hypermobile first ray, we're going to have to address this. So drop down from that. See, we have a red plus there. So in this patient, we would have to do, if they had a foot type that showed a rigid rear foot but a supinator end range motion which was high in the first ray, we would need to do osteotomies on the second and third, take care of our gastroc, and also stabilize the first ray. Now, if the patient had a flexible rear foot and a flexible forefoot, the first thing we're going to do, as we talked about in the early stages of the talk, we have to convert this flexible foot to a rigid rear foot, flexible forefoot. So in that case, you do a hypercure to take care of your rear foot. Then you would do, most likely, the second, third mets, and you need to do your gastroc, and in some cases you have to also address your first ray. Not always, because sometimes when you put the hypercure in and you do the gastroc, your first ray will now have mechanical advantage due to lack of overpronation, and the first ray will not need to be addressed. Now, how do you know if it needs to be addressed? That is another talk, but that's when I use the Peacock press. So, for example, if I were to do a hypercure on a flexible patient who had a second, third met, I would then use my ultrasound to kind of gauge where those metatarsal heads are in the vertical position. So that's a different talk. So we'll also use that as well. There's some other things we use too. You don't want to deny that we don't use X-rays. We certainly do. One of the things I go by a lot is the way the first ray and the talus look on the lateral X-ray, known as the Meares angle. So if that's increased, and you're probably going to need to address the first ray. So a highly increased Meares angle would cause me to always do the first ray, whether I did the hypercure or not. So we do look at X-rays too. I look at standard AP X-rays to look at metatarsal length. I do lateral X-rays to look at how the first ray is functioning with respect to the talus, and also whether or not we can see our sinus tarsus. And also I examine the patient with X-rays to find out whether or not the rear foot is flexible in neutral calcaneal stance position, and also in weight-bearing calcaneal stance position. So we look at that as well. as the things we're looking at today. So what I wanted to get to come through with this talk is basically that foot typing is important. I use this particular system because it's easy to use, it's easy to make sense of, and in no way means that other systems are not just as viable. There may be systems that are even better. I don't know. This is the one I use, and like I said, I'm not a biomechanics expert. This is just an easy to understand system for me. So let's look at a patient. We'll look at an actual case just to kind of look at this. Here's a case where a patient had a third metatarsal pain. So he had a positive gastric equinus. So what procedures we're going to do? This patient had more of a rigid rear foot and sort of what I call a stable forefoot, but still had the pain in the first and third met. So we did osteotomy on the second, third, and fourth. You can see that. That's in the OR, and it shows our percutaneous osteotomies. This is a patient, a fairly nice patient to look at. This is a dislocated second met. For this patient, her pain was obviously in her second met. And if you look at post-op 6 months later, we did the second, third metatarsal osteotomies. We also did osteotomies of the second, third, and fourth toes. This patient did not have gastric equinus, so we were able to perform basically second and third metatarsal osteotomies. We also performed something that's kind of unique to minimally invasive surgery. We performed a Haspel procedure, which that's a procedure where we do our osteotomy, but we'll also do a osteotomy in the plantar aspect of the metatarsal, allowing a cut through the condyle area. This allows us to correct dislocated second metatarsal joints. And to show this patient clinically, this is the dislocated second metatarsal at pre-op, and then this is 6 months later. You see our toes are lined up real well. We didn't have to do gastric equinus for this patient. Just to kind of make this talk complete, I'll talk about a Peacock press. Peacock press obviously is when we look at the metatarsals with the ultrasound. In this patient, you can see where preoperatively we have, you can obviously see this, those are the second, third, and fourth metatarsals from medial to lateral. You can definitely see where in this patient the third met is kind of down, and you can see inflammation on this. And we can measure this, and in the top right of your screen you see the immediate post-op, and we got measurements here. It shows how our foot looks after the surgery here. This is the same patient. This patient had a rigid rear foot, flexible forefoot. So we're able to get by with second, third, and fourth metatarsal osteotomies. You can see the dorsal aspect of the foot here where we made the incision. It's 2 weeks post-op, and we can look at this with and quantize this with our ultrasound. See our pre-op measurements there. You can see your immediate post-op, and then 12 weeks later, you can see where our metatarsals are kind of aligned. This patient went on to complete recovery of pain and no pain at all. So anyway, what I use foot typing for, I've started using that for many different types of people that come into the clinic. And if you assess this, what you'll normally see in podiatry, your most common patient is going to have a rigid rear foot and a flexible forefoot, and you're going to have a lot of patients with flexible rear foot, flexible forefoot. And if you start narrowing this down, it becomes easier to correct. Matter of fact, metatarsalgia was oftentimes very hard for me to correct until I started getting better at minimally invasive surgery. And I used minimally invasive surgery along with foot typing to kind of help these patients and determine which procedure I'm going to do, and based on what kind of problems they have. Now, to make this complete all the way, we're going to look at the formula one more time. And if you look at the very bottom of the formula, you see where it says global. We often have patients come in that have pain all the way across the forefoot. And these are patients you don't know exactly what to do because their foot hurts all the way across. This can oftentimes be neurological pain. Oftentimes I'll do a deep perineal decompression of these patients to get rid of the pain, and I assess these by just doing an injection into the area, and if the pain goes away, we'll do a deep perineal decompression. If it doesn't go away, we look at their foot type. If they have a rigid rear foot and a flexible forefoot, most of the times on these patients, their pain is all the way across the forefoot. I only will do the gastric recession because most of the time that's what they're going to have. Now, if these patients are global and they have a flexible rear foot and flexible forefoot, and the pain is all the way across the forefoot, oftentimes I will only do the hypercure and whether or not they have gastric or not. So some patients are going to have pain all the way across. You need to kind of know whether or not it's neurological, whether it's coming from the deep perineal or some nerve compression, or whether or not this is biomechanical. And this obviously would apply also to our cavus foot. We're not talking about cavus foot, but in cavus foot patients, it's oftentimes easier just to do the soft tissue releases like the gastroc recession or the TAL in these patients. So just to make the talk complete, I'm going to try to get a publication out of this type of thinking, and we're already working on that, and so that it'll be easier to read. Some of this is already in the literature under the Peacock Press, but I'm going to try to do a metatarsalgia talk in a presentation here shortly. I'm actually studying this and actually getting data together, so I'm hoping to get a really good publication with actual data on this. Anyway, I appreciate giving you the talk this morning, and I hope this helps and lets you know how I'm using foot typing and why it is important for the patient. But I want to leave you with this. With all of this stuff we've talked about today, we do know, and all of us are aware that do surgery, this surgery is mostly an art. It's not so much a science. This only helps the art to know the science. The art is still the most important. And when we look at things that are theoretical, like biomechanics, there's no perfect biomechanics as far as I'm concerned. I don't think you can make a perfect biomechanics of the foot. It's too complicated for that. I think the foot typing I use is simple, and it gives us a ballpark where to go from. It's not the perfect thing. I can already tell you that I see some holes in this particular foot typing, and I've seen that in everything I've looked at. I'm not a biomechanics expert by no means, so the people that are good at that, you need to ask them those questions. I don't know a lot of that theoretical stuff with biomechanics. Mainly I use biomechanics to help me know how to treat patients surgically and conservatively, and that's where I keep it at. So I think there's theory, which is great, and we need to keep doing that. But there's also real-world application. This particular foot typing has great real-world application. Now, when I talk to people about this and know more about the foot typing and this system, they basically lose me. I'm not sure what they're talking about. The theoretical stuff with the things that we get from other scientific endeavors like physics are basically very in-depth and hard to understand. This is more a practical way to treat a patient, and it's the way I do it. And so far, it's helped a lot. Not every patient's gotten better, but majority have gotten better using this, and I've got success rates way in the 90th percentile rate with this. So I appreciate you listening, and if you have any more questions, we'll try to clear up what we need to.